Thank you so much for joining us today for this virtual event on the future of lung cancer care and prevention. Want to take this moment to recognize that this is a pretty weird time in the world right now, so we thank you for taking the time to join us online. My name is Samantha Cook, and I'm a philanthropy officer at the Swedish Foundation. Swedish is actually the largest nonprofit healthcare system in Washington state, and it's based right here in Seattle. I'd also like to take a moment to thank our donors who are joining us today, especially the law firm of Bergman, Draper, Osland, and Uso, as well as the Gittinger family and the Friedman-Rieger family. Without your support, we couldn't do the innovative work that we're going to be talking about here today. And then just a moment before we get started, I'll run through how things are going to work today. Dr. Valliere is actually in surgery right now. He's doing what he's here to do. And so he won't be able to join us, but we have a great discussion still that we're going to move forward with Dr. Adam Bograd and Dr. Jed Gordon. I'm going to be hopping into the moderator seat here, so it'll be great. Yeah, so without further ado, let me introduce Dr. Jed Gordon, who's going to say a few words about the lung cancer program here at Swedish.
Hey, Samantha, thank you very much. So I'm Jed Gordon, and I really appreciate this opportunity to talk to you and show a picture of me, what I looked like probably 20 years ago. Definitely do not look that young now. I want to apologize on behalf of Dr. Valliere, who is in surgery. Dr. Valliere is the chief of the Division of Thoracic Surgery and Interventional Pulmonology, and actually really deserves a lot of credit for building one of the premier not only the premier, but one of the largest thoracic surgery programs in the Pacific Northwest and nationally. And one of the things I think that's most interesting about this is just in the name itself and what he envisioned when he was creating this, which is the Department of Thoracic Surgery and Interventional Pulmonology. And this kind of union of these two specialties is unique. This isn't something that happens nationally or has been reproduced in many centers. And the value add of this, what it brings to Swedish and what it brings to our department, is that we actually have the capacity now with thoracic surgery and interventional pulmonary working together to work to create a soups to nuts approach from early lung cancer detection on one spectrum all the way through palliation at the other spectrum with diagnosis, staging, and innovative care in the middle. And that's what we're going to talk to you all a little bit about today. But I'm really proud because I think that what we have here is quite unique nationally. And it's a real asset and a real reason to recruit and come here to Swedish is this innovative program design that Dr. Valliere really is responsible for building. But really what we want to talk to you about today and answer any questions as they come along is this journey, this notion of early lung cancer detection, where things stand here and what we're doing here at Swedish in our research programs and our clinical programs, all the way through treatment, which Dr. Bograd's going to talk to you about a lot with not only just treatment, but innovative treatment and participation in national trials and ensuring that this innovative care is available to all of our patients. And so that's kind of a backdrop of who we are. And I'd like to let Dr. Bograd sort of talk a little bit about himself for a minute, and then we'll dig into each one of our specialties and talk a little bit about our research interests and how our program is really made up.
Thanks, Jed. Thanks, Sam, for giving me a chance to talk today. I guess my picture is a little more recent than Jed's. So I came here from New York City. I did all my medical training in New York City. I did medical school at Columbia. I did a formal clinical research fellowship as a medical student. And then eventually I went on to do general surgery at NYU in New York. In residency, I did something that sort of changed my career trajectory permanently, which was a formal research fellowship at Memorial Sloan Kettering in the lab of Michelle Sadolin, where we focused on research exploring the use of targeted T cells, this sort of so-called CAR T cell treatment, as a therapeutic modality for early stage, advanced stage lung cancer, as well as mesothelioma. I subsequently went on to do my research fellowship, my clinical thoracic surgical fellowship at Sloan Kettering in New York as well, where I focus solely on thoracic surgical oncology. And so it follows my main interest and passion is the treatment of thoracic malignancies, in particular lung cancer. And so one of the things I was hoping to bring here, and one of the things I was asked to do when I got here, was to sort of beef up the participation in therapeutic clinical trials for patients with resectable lung cancer. And more specifically, building on some of the interests which were fostered at Sloan Kettering, both clinically and in the lab. My focus here is primarily on early phase clinical trials, which seek to incorporate immunotherapy into the treatment algorithm for resectable lung cancers. And we'll talk a little bit more about this as the program goes on, but immunotherapy in its sort of broadest definition is something that uses the body's immune system to fight off cancer, and it's a biologic therapy, and it's a living drug in sort of the truest sense of the term. So that's a little bit about me and sort of my interests, and we'll get to talk a little bit more about this later in the program. Thank you.
Thanks, Dr. Bograd. Dr. Gordon, you did a great job of giving us an overview of the program, but can you tell us a little bit about who you are?
Yeah, thanks. I appreciate it. Thanks, Adam. So again, like I said at the beginning, my name is Jed Gordon. I'm an interventional pulmonologist, but my background starts off in medicine. So I went to medical school in Nashville, Tennessee at Vanderbilt. And then for those of you that aren't familiar with medicine, you go from medical school to a residency, which is a lot like the draft. You get an envelope one day, they're all opened at the exact same time across the country, and that's where you go. And I was fortunate enough to come out to the Pacific Northwest and do my internal medicine program at the University of Washington. And at the University of Washington, I became really interested in pulmonary and critical care, which is really the study of lung disease and intensive care unit medicine. But at the end of that fellowship, I was really struggling to sort of identify what my niche was going to be. How was I going to distinguish myself in this large field that encompasses everything from asthma, emphysema, cancer? And so I went on and did a third fellowship, right? Because training never should end. So I did pulmonary critical care, and then I moved to Boston to the Beth Israel Deaconess, and I did what's called interventional pulmonary. And this was an emergent field when I started. It was brand new. I was one of the first 6 or 7 people to sort of define this program nationally. And what it allowed us to do as medicine-trained doctors, not surgeons, but medicine-trained doctors, is become more intimately involved in thoracic oncology, to learn about thoracic oncology itself, to participate in its diagnosis and staging, and to understand sort of the needs that patients go through in their journey from an early stage cancer all the way through advanced cancer. Then all of a sudden, in about 2011 through 2015, this notion of lung cancer screening or early lung cancer detection came on the scene with large national trials, and then finally Medicare acknowledgement of it. And we actually here at Swedish in the thoracic surgery division had actually been participating in lung cancer screening in its earliest phases, even before it had been approved by Medicare, and had been building a clinical program here. And my specific interests in this actually not only have to do with advancing early lung cancer detection so we can shift the diagnosis from late stage to earlier stage, but actually in disparities. There's not equitable distribution of many of the healthcare resources that we have in this country. And so we have built a research program that we'll talk a little bit more about later on early lung cancer detection, specifically disparities and broadening access. But what I do want to mention is that in interventional pulmonary specifically, we're super fortunate. So we have a large philanthropic grant that is entitled the Center for Lung Research in honor of Wayne Gittinger, which has actually really allowed us to build the infrastructure for a sustainable research program. And there's something really unique about our research program that we've been able to build, which is a model built on mentorship. So this program does clinical-based research in all the areas that I told you about, but it brings in students interested in the healthcare services, whether that be masters in public health, whether that be medicine, whether that be nursing, and trains them for a year or two in research, and then they go on to their chosen careers. And we've been enormously successful with a little over 10 participants, all of which going on to their careers of choice the majority of which are medicine, but some have been health services researchers. So we are extremely fortunate to be able to have this sustainable program that not only allows us to do research, but actually mentor the next generation, which is another unique thing. People looking for research opportunities at a younger, more foundational age, there's not a lot of opportunities for them. And so it's pretty gratifying and very unique for us to be able to do that. And we'll dig more into some of these research projects as we go along, but I sort of wanted to kind of introduce how our program in interventional pulmonary is set up.
Awesome. Thank you so much, Dr. Gordon. We are going to move into our discussion portion of this afternoon's program, and we're going to start off with a question for the audience. This is going to be another poll question, just like you did at the beginning. And so we're going to ask, which of the below could be a symptom, a sign or a symptom of lung cancer? A cough that does not go away, coughing up blood, loss of appetite, shortness of breath, or all of the above. And while you guys are filling that out, like I said, we're going to go into a kind of moderated discussion. It's very casual with Dr. Gordon and Dr. Bograd. And then as you guys think of questions, please use the Q&A box that's at the bottom of your screen there. On most screens, I'm not on an iPad, so yours might be a little bit different. But use the Q&A question box to send us questions, and we're going to ask questions kind of toward the end of the program here, but we'd love to hear from you. We want this to be interactive for you guys. All right, so it looks like almost everyone said all of the above. And so I'm going to turn to Dr. Bograd for our correct answer. Oh, looks like, there we go.
Yeah, sorry, muting. So you're correct. It's sort of all of the above. And lung cancer can have lots of different signs and symptoms. So different people have different symptoms for lung cancer. I mean, some people you wind up with symptoms that are related to the lung itself. Some people wind up with other symptoms if the lung cancer has moved into other parts of the body or metastasized, and they can have symptoms that are very specific to that part of the body. Some people have symptoms, just this general feeling of not feeling well. But quite a few people with lung cancer don't have any symptoms, and the tumors are found incidentally while getting imaging for other reasons or getting it for lung cancer screening, sort of stuff that Jed was just talking about. And so symptoms can run the gamut from coughing, chest pain, shortness of breath, wheezing, coughing up some blood, just feeling tired, unintentional weight loss, or nothing. And, one of the things that has been coming into play recently is that there can be some gender differences in how people present, and in particular, for women, there's some studies that suggest that compared with men, women who smoke actually develop lung cancer at an earlier age and with less smoke exposure. And so, where you may not be necessarily thinking about a 40 some odd year old male having lung cancer, where it may not even be a second thought, you got to start thinking about it in women at an earlier age. Study results are a little bit conflicting and inconclusive about whether or not women are more actually susceptible to smoking effects, but there's some hypotheses. We do know that there's some genetic data that lung cancer is not biologically identical in women and men. So there's a lot of sort of emerging gender-specific data, and so they can take on a lot of different presentations, and in particular, they may not have any symptoms, and it might be picked up totally serendipitously on imaging that you're getting for something else.
Yeah, that's one of those things. This reminds me of the discussion that everyone's having right now around COVID of like, wow, this sounds like having allergies, or this sounds like having a cold. Is there anything that you can point to that says like, yes, you should go get screened? Who should get screened, I suppose, is maybe a different way of asking this question.
Well, so I'll jump in for just a second here. So, one of the challenges that lung cancer and physicians have always faced is that the lungs are silent. We don't have pain receptors in our lungs. We don't have the normal sensation in our lungs that say, if you touch a hot surface, you pull your hand away, or if you have a visual sign of something that may harbinger something worse. The lungs are essentially silent until they aren't, which means you're starting to have symptoms, which means that something is encroaching on an airway, on the wall of the lung, which has pain receptors. And so that has been the challenge. And unfortunately, because of that challenge, the data has always revealed that the overwhelming majority of lung cancers are diagnosed at a later stage. And a later stage means that they're harder to treat, they're harder to cure, and they pose more challenges. And so what's one of the really great advancements of our lifetime is the acknowledgement that lung cancer screening holds a benefit. Now we have to remember that lung cancer screening implies that people are asymptomatic, right? This is the same as women who go and get mammography, or that the whole population who goes and gets colonoscopies. These are people who carry risk, whether that risk is based on gender and age or whether it's based on smoking status. We are hoping to shift this by picking up these cancers earlier when no one would have symptoms, and we do a much better job of treating them. And so there's pretty standard guidelines on this. There was a large trial that was published, 25,000 people in each arm, about 50,000 people, comparing lung CTs, which are the computed tomography scans, the super sensitive images of the lung, and regular x-rays that people just get, which are just kind of an overview of the lungs. And it was found that images with CT scan had a far superior ability to identify cancers at an earlier stage than chest x-rays. And so the recommendation, and then CMS, which formally gave its blessing and approved it, is that people that qualify and the current people that are scanned and screened are between the ages of 55 and 77 years old. They're active smokers, or they quit within the last 15 years. And they smoked a total of 30-pack years, which is a pack a day for a year, or 2 packs a day for 15 years. Pack a day is sort of how we kind of measure tobacco exposure. So that's the population that is recommended for screening and actually qualifies for screening, and that we're currently screening in. But they have to be asymptomatic as well. If people are presenting with symptoms of cough or other, then they're not actually in the screening category. They're more in the investigative category of why do they have symptoms. And it's a really powerful technology. It's reduced lung cancer specific mortality significantly by over 20%. And it actually showed to reduce overall mortality in this population by just under 7%. And so this dual thing of looking for lung cancer and bringing people into the healthcare system is super powerful. But there's a problem. We're not taking advantage of it as a country. Probably less than 10% of the eligible population nationally actually goes out and gets screened. We're struggling to really implement this on a national level. And that's one of the things that we're particularly interested here at Swedish. We have a dedicated lung cancer screening program. It's staffed by nurse practitioners with a tremendous amount of knowledge on tobacco cessation, lung cancer screening, and there's a lot of different steps that people have to go through. But one of the things that we've learned through our research is that the median distance that people travel to go for lung cancer screening at either a Swedish site or a Providence and General site is only about 7 miles. And we know that in Washington State, there's 113 accredited CT screening sites. The overwhelming majority of them fall in metropolitan areas that fall into the Seattle, King County area, which leaves our rural areas. It leaves our other sort of underserved and under-recognized communities with both less access and less ability to get screened. We were fortunate enough to just get a grant, a secondary grant to our primary philanthropic grant, to specifically study barriers to lung cancer screening in Alaskan Natives and American Indian populations. And that's something that we're working on now to try to figure out specifically why this population, which has higher smoking rates and suffers significantly from lung cancer, is being screened at a lower rate than most populations. So we have a powerful tool. We have specific guidelines, albeit they're not the best guidelines, and they're continue to need to be refined to figure out what the best population is, but they're a good starting point. But the next step is to work on access and make sure that this is available to all communities and that we're continuing to promote it, and not just passively promote it, but actually work to suck people into the system when they need to be, stay in their communities when they're best served in their communities. Because we know that taking time off work, traveling into the city, parking, even in the COVID era and the non-COVID era, is a challenge for many people. So we want to work to do this. And that's both what our clinical program and our research program is doing in this area. And it's a really exciting area. We've been involved in it for years, and we plan on being in this space and be leaders in this space going forward.
That's great. That kind of leads me to my next question of, you've talked a little bit about your efforts to screen people in rural areas, screen people who don't normally get screened. Is that connected to your work at the Center for Lung Research? Can you tell us a little bit about what you guys are doing over there?
Yeah, so, one of the things that in thoracic surgery in general, and Adam will talk about this in the areas that he's working, but one of the things that we do is our research programs are intimately coupled to our clinical programs. So it's very important for us to identify clinical problems, clinical deficiencies, areas that we still have knowledge gaps, and then study them. When you say that you're the best center for either thoracic surgery or interventional pulmonology, that's a pretty static statement, right? In order to be the best center, you have to continue to question, you have to continue to push the envelope, you have to continue to find new answers. Because if you think you're the best, you're probably resting on your laurels, and you need to continue to sort of push that envelope. And so our research programs are intimately tied to our clinical programs. So the Center for Lung Research works in parallel with the clinical program for lung cancer screening on this aspect of early lung cancer detection. We have a clinical program that has nurse practitioners that are actually seeing the individual patients. We take a tremendous amount of information and data going from there. But then we work with the Center for Lung Research to do mapping. We have a GIS mapping service where we're mapping all of the locations of lung cancer screening, both in the Washington state and nationally. We have a program where we're mapping populations at highest risk, not just those that meet the criteria that I told you based on age and smoking, but where densities of minority populations, African-American, low socioeconomic status, low education rates, things that track with higher rates of lung cancer. And we map these areas, and we work to create clinical models so that we can go out and attract those individuals. So I think the best thing to say is that the Center for Lung Research is our research thing. It's an entity that's designed to both understand what's going on at Swedish, but also what's going on nationally and how we can move that forward. But it works in concert with the questions that we're identifying through the clinical program and finding deficiencies. And I think that's really what defines any program, wherever you are, that wants to call itself the best, is that you're only best for a short time, right? Because someone's going to continue to work, and that's what we're doing to kind of continue to advance what we're doing.
I think that that's really great to hear about how your research directly connects to your clinical practice. Can you give us an example of that in practice, either of you guys, of a time when you were able to take something that you were researching and use it to improve a patient's life?
Well, I can tell you a little bit how we can take it to improve our program, which we hope all these programs are improving people's lives. If you take the lung cancer screening program, the way we improve people's lives is by identifying cancers early, and then Dr. Bograd and his surgical colleagues can actually cure that cancer, and we define it earlier. So the broader reach we have with this program, the better off we are. That's how we help patients. So one way that we can couple our research and show you tangible evidence for that is that in working through both our data and data through the entire Providence system, we've identified that the median distance, the distance that people are willing to travel to get screened, is only about 7 miles. And we know that the further people live away from a screening center, the less likely they are to get screened. This holds for mammography and breast cancer, and it holds for lung cancer. So if we were to say we're the best lung cancer screening program for people that live within 7 miles of a Swedish center, that would be great. A lot of people live within 7 miles of a Swedish center, but we would be ignoring many people who don't live in our area, who have higher smoking rates. If you take smoking rates in King County, they're less than about 14%. If you take smoking rates outside of that, they can exceed 20%. So our model is to combine a centralized program now with nurse practitioners here, and then create air traffic controllers that can help coordinate with primary care docs who are out in the periphery in order to identify their patients with lung cancer risks. They get screened. Those that just need surveillance stay in their community. They never have to travel. Those that have a higher risk can then travel to Seattle, but it's an inverted pyramid. Majority of people get to stay home. They don't have to travel. They don't have to pay for parking. They don't have to come into the city. And only a very small number at the bottom will come out. And that's sort of coupling our research program with our clinical program in order to identify that we had significant disparities. Even though we were able to provide a real quality service, we weren't able to provide a depth and breadth of a quality service. And the other area is to identify that we didn't have tremendous minority participation. We are far from unique in that. If you look at the National Lung Screening Trial, which was a national trial, 97% of the population was white. The overwhelming population was male. We know that we need to reach out to more. And so we have this grant now where we're looking at American Indian and Alaska Natives in Washington State and figuring out how we can specifically outreach to these minority communities. And this is how you kind of take a program that's screening people every day, but then figure out how you can make that screening program better. And you can only do that if you continue to question, look, and try to advance the field.
That's great, Dr. Gordon. Thank you. I'm going to switch gears a little bit here. I want to hear more from Dr. Bograd about some of the clinical trials that he's working on. And I want to start with the very basics. What are clinical trials? How do they help patients today?
Yeah, so good question. So one of the things that I was hoping to answer today was to give people sort of an idea in terms of discussing clinical trials, sort of generally, like big 30,000 foot view, and give people a sense of what they are, what the purpose is. And so you'll probably hear a lot of different terms and phases of clinical trials being used. So let's talk about those first. So typically clinical trials are listed between phase 1 and 3, most commonly, with phase 1 being the earliest. And what you're looking at in a phase 1 trial is simply, is the treatment safe, right? These are usually smaller studies that tend to enroll, between 20 and 100 patients. And the big question is whether or not the drug is not whether the drug works, is it effective, but whether it can be given to people safely and what are the side effects. And you start to get some sort of rudimentary information about what's the right dosing. And you do look for some data to see if the drug works, and everybody's really happy when, you see a signal that things are working. But that's not really the focus of a phase 1 trial. That's really the emphasis of phase 2 trials. And when people mention early phase clinical trials, they typically are referring to phase 1 or phase 2 clinical trials. So in phase 2 trials, you're typically asking, is the intervention or the drug or the treatment or whatever you're looking at, does it work? Is it effective? And you're also trying to figure out at what dose, right? There's dose escalations in some of these studies. Which dose works the best with the least amount of side effects, right? And these are typically slightly bigger studies than phase 1 trials, are between 100 and 300 patients. And then the last or most common clinical trial that we deal with here are phase 3 clinical trials. And so the main question for these is, does it work better? And more specifically, should this be the new standard of care, or should it be part of what the standard of care is for a treatment? And so you're usually comparing whatever your study drug or intervention is to an existing standard of care or an existing gold standard. And these are where you typically come into randomized trials. And so these are often several hundred to several thousand patients in size. You tend to have multiple institutions participating. And so you're really trying to, number one, confirm the drug's safety and effectiveness compared to some sort of gold standard. Like, what is the gold standard treatment? There are a lot of benefits to participating in clinical trials. So the first, and what's typically most important to patients, is you get access to experts in the field. Not everybody is participating in clinical trials, and you wind up, as part of your disease treatment, receiving care under people who are sort of most caught up with the current treatments and trends in that field. You also have the possibility to be treated with a new drug that probably has shown effectiveness either in preclinical trials or on earlier phase studies that's not available to the public, right? And there's a sort of greater good aspect of it, right? You increase disease knowledge, it supports drug development. And so to put a little bit of this sort of why clinical trials are important into context, there's about 90 FDA approved indications for immunotherapy over, I think, just over 20 different cancer types. And so the point of me mentioning that is not to sort of run down every single individual cancer type or enumerate every single type of immunotherapy that's been approved, but just to give you an idea of the sense of sort of how important clinical trials and clinical trial development and participating in clinical trials have been in the development of immunotherapy. And so I feel very confident in saying that none of this would have been possible without clinical trials. So all these cancers within the context of being treated with immunotherapy were tested in phase 1 through 3 clinical trials in order to get approval. And so all these medications that you're seeing, at 9 p.m., people talking about Opdivo on television, none of that would have been possible without clinical trial participation.
Adam, can I ask you a couple questions? So
Sure.
We know that national participation in clinical trials is low. Not everyone participates in clinical trials, and there are unfortunately racial and ethnic differences in participation, which causes challenges for many of the things you're talking about. Can you give me a sense of two things? One is, can you give me a sense of what is it like for someone to be in a trial? I mean, is it a burden? Is it a benefit? Is it what does it look like for someone who is actually going to participate in a trial? There's lots of questionnaires and things. Can you talk about that? And then I want to ask you, you talked about immune therapy, and I want you to dig into immune therapy. Let's say someone's on a clinical trial. Can you help us understand immune therapy is your immune system, right? So how does it know a good cell from a bad cell? How does it know to attack the cancer? What is this sort of therapy and how is it working if someone was on a clinical trial, and how does it know? So can you talk to both of those a little bit?
Yeah, so I'll answer the first question first. So, a typical participation in a clinical trial usually is not an excessive burden for patients. And I freely admit that I have a bias on this. I think that the advantages to being on a clinical trial far outweigh the disadvantages to being on a clinical trial. So there is a very sort of extensive and thorough screening process that goes into who you select to go on a clinical trial. There's very extensive inclusion and exclusion criteria. And the thought of that is you want to have as narrow a population as you can possibly get on trial where you feel will be safe, right? Where you feel you're not going to subject people to unnecessary harm. So that's number one. There's a myth that, I've had a couple people say they don't want to participate in a trial because they're worried about insurance issues, right? Insurance may not cover the, certain costs of care involved with a clinical trial. That's more often than not the case. That doesn't happen. There is, known budgets for each of these clinical trials. Most of the treatment that people get, even if they're on a clinical trial, is still standard of care. So it's covered by insurance. And then the costs that go above and beyond that related to the study drug, they're usually picked up by the study sponsor. So there shouldn't be any excessive costs for people. And I've had to explain that a couple of times this year in the office for people that I've been asking to go on trials or not. There is also a sort of a myth that, once you sign a consent form for a clinical trial, you're sort of locked into staying on that trial. That's not the case either. You always have the last word, and patients always have the last word in saying if they want to participate or not participate, and they can opt out at any time. So I think that those are important. There's no extra costs, and you're not permanently stuck doing something, and nobody's going to withhold standard of care from you if you decide not to participate in a clinical trial. That's never the case. Really what it looks like in terms of how much of a time burden it is on somebody, it varies from trials. And I can't talk too much about the specifics of the trials that I'm running because I've signed NDAs on them. But, there's one trial now that is almost open where the burden on patients will be a lot less than what's the standard of care induction or preoperative treatment for lung cancer, right? So usually for preoperative treatment for lung cancer, you get between 4 and 6 rounds of chemotherapy, right? One of the studies that we're looking at now, you get 2 30-minute infusions.
Wow.
And so it's less time, and the side effects are a lot less of the medication that we're planning to use. So I do think there are some benefits. You know, there are some trials that you require more imaging, right? So you may have to do some more imaging, namely either a CAT scan or a PET CT. So that can be a little bit of a time burden, but there's a reason and a rationale for that. And again, the cost of those extra studies is, I would say, 99.99999% of the time picked up by the study sponsor. I can talk a bit about immunotherapy now if you want, or I can hold off to talk about that.
I'd love to hear about it. You mentioned it a couple of times.
Let me jump in real fast, Sam. Let me jump in real fast, and then I want you to talk about the immune therapy. So I also want to sort of emphasize that clinical trials come in a number of different flavors. So one of our interests is more advanced cancer. Unfortunately, not everyone has an early stage curable cancer. Many people have a late stage cancer, and we need to figure out how to allow people to live the best life they can live, the most independent life they can live. And so some of our research is on quality of life. And so you could participate in a quality of life study where we're looking at managing fluid that builds up around the lung. So the lung is like going to the grocery store, getting your groceries in a double plastic bag. Fluid, because of cancer, can build up between those two plastic bags and push the lung out of the way and make people short of breath. There's different ways of managing it. And we may ask people to participate in a trial where we just get their quality of life, or they fill out symptom questionnaires. So research can come in many different flavors that allow us to figure out best treatments to revolutionize how we deal with things, but also best quality of care so we can better understand what people are going through so that we can help them live better, independent lives. And so sometimes questionnaires are involved, and sometimes we participate with loved ones. We ask them, cancer is a family disease. I strongly believe that the family, the larger circle is involved. So how does the caregiver feel is very important. We need to figure out, are people feeling empowered? Are people feeling disempowered? Do they feel that they're a burden? These sorts of things. And understanding these dynamics help us give better care. So this clinical research can come in a large spectrum, but maybe let's say you are participating in a clinical trial. I'm fascinated. You talk a lot about your trials that are going on with immune therapy. And if I turn on the television at night, in between the 97 side effects that they all have, they use the word immune therapy. So how is my immune system able to figure out a bad cancer cell from a good cell and not sort of cause all those problems?
Yeah. So, I alluded earlier that in what you just mentioned, my main research focus is, again, sort of trying to incorporate immunotherapy into the treatment algorithm for resectable lung cancers, either in combination with chemo or as a replacement for chemotherapy. And so the type of immunotherapy that's most commonly being utilized right now and being utilized as a study drug are immune checkpoint inhibitors. That's sort of a big classification, and I'll go into that in a second. Immune checkpoints are normal parts of the immune system, and the role of an immune checkpoint is to prevent your body's own natural immune responses from being so strong that it'll destroy normal, healthy cells, right? So those checkpoints are in place to prevent your immune system from going haywire and attacking itself. So that's the first point that's important to know as a basis for what I'm going to say next. So the way immune checkpoints work is there are certain proteins on the surface of immune cells called T cells. They're a very specialized immune cell. Those T cells recognize and bind to a partner protein or a sort of something on the cell surface of other cells, so tumor cells, for instance. And these proteins are called immune checkpoint proteins. So those immune checkpoint proteins are on tumor cells. When the checkpoint and the partner protein bind together, essentially what happens is it gives an off switch. It puts a brake on the T cells, right? The immune cells. And that prevents the immune system from both recognizing activating and engaging cancer cells. So there's a natural off switch that's there, and some tumors upregulate or they produce more of that off switch protein. So immunotherapy drugs called immune checkpoint inhibitors, the way they function is they block that interaction between checkpoint proteins binding from its reciprocal or recipient on immune cells. And so what happens is it prevents the off switch or the off signal from being sent to the T cell. It allows the T cell to recognize cancer cells, and it allows it to hopefully kill those cancer cells. That's sort of the biggest simplification of it. And there's a lot of really good preliminary clinical data from pilot studies all over the world that using immune checkpoint inhibitors, either in combination with or instead of standard of care chemo, is more effective than using chemotherapy alone. So that's sort of the main.
I just wanted to say that's a huge statement right there.
Yeah. So that's sort of the main sort of big picture of it. And I think immune therapy is probably the most exciting thing going on. Again, I was lucky. I was in the lab, 2010 or so, sort of at the start of all this. And one of the questions you asked before I didn't have a chance to answer of it was, have you seen anything you've done in the research realm make it into clinical practice? So I saw a receptor that I helped make in the lab in 2010, and I'll talk about this in a minute, get put into the first patient when I was a clinical fellow in 2015. Wow. Yeah, so it was pretty neat, and it worked. So that was the best part. So that's probably probably the most common category that we hear about nowadays in terms of immune therapy. There's a second type of immune therapy, and this is some of the stuff that I worked on as a research fellow that's making its way into solid tumors now. Whereas, most of the current data is now on sort of blood cancers. It's called adoptive T cell transfer. That's sort of the next big step in solid tumors, and I'm sort of in the process of trying to get one of those studies here for mesothelioma, not lung cancer, but meso. So it's called T cell transfer, and that's a different type of immunotherapy that uses your body's own immune cells to attack cancer. There are two main types of it. One is called tumor infiltrating lymphocytes. That doesn't really have much of a role in lung cancer or meso, but CAR T cells, and CAR stands for chimeric antigen receptor. This big picture, this involves collecting your own immune cells, right? So a blood draw, you grow them out in the lab, you essentially infect them with a receptor that'll recognize a certain protein on cancer cells, and then those cells are given back to you intravenously. And so it has a whole bunch of different names: T cell transfer therapy, adoptive cell therapy, adoptive immunotherapy, immune cell therapy. There's a whole bunch of different names. It's a longer, more drawn out process. This is not really off the shelf stuff yet. The process of growing your own sort of bespoke T cells, I guess, for lack of better words, takes anywhere between 2 and 8 weeks. Most people, it's about 6 weeks. And so during that time, most people will wind up getting chemotherapy or radiation therapy. And one of the tenets to doing this is you have to deplete your own immune system before you give somebody back these targeted T cells. And that helps those cells be more effective. And so I think that's sort of the next thing on the horizon. Quite frankly, that's the thing that I personally am most excited about, is these designer T cells. I've seen a lot of the preliminary data for mesothelioma, and it's very effective in patients who there is nothing else that can be done. I mean, we're talking about people that have probably seen 3 or 4 other lines of therapy who are now showing responses to this. And so I am sort of in the works with the lab that I worked in to try to be one of the first sites to get CAR T cells for solid tumors here.
We're lucky to have you here at Swedish then.
Thank you.
Yeah. Was there anything that you wanted to jump off there with Gordon?
Yeah. So I want to actually throw a question to both Adam and you, Sam. So let's say that do we at Swedish, can you tell us a little bit about our capacity to bring participants to benefit from all the things that you're talking about who may not live within 7 miles of a Swedish site, and the ability to kind of participate? Are there both how, how has Philanthropy helped that? It's Swedish, but also, Adam, are you, we're a hub for people who come from Idaho, Wyoming, Alaska, areas that don't have many of the medical resources that exist in a urban center like Seattle and a Swedish. So how can we sort of help to continue to make sure that we're really not just doing research on people who live within 7 miles of us?
So actually, that's a question that we just had come in. Was someone was asking, would clinical trials be accessible to those who don't live in the Seattle area? Sounds like you're saying for most of these people need to live within 7 miles.
No, I was using the 7 miles because that's what we found in our lung cancer screening study, that we
Gotcha.
mostly deal with people who are close by, but I just want to make sure that people who don't necessarily live close by continue to have access to some of this work that Adam's describing.
Well, I can jump in and say that at the foundation, we have a fund specifically for helping people who have to come from further away. Further away can mean lots of different things. So I'd actually love to hear Dr. Bograd's thoughts on this. If someone is living in, a different part of Washington state, do they have to live within an hour's drive or something like that? I know that that's a big thing in clinical trials in the blood cancer space. Is that true in lung cancer as well? And just to finish up my bit, yes, we have funds available for people who have to travel. That's something that we are actively fundraising for right now to make sure that we can reach more people, not only because we want to help more people, but because it's critical to having a successful clinical trial, to have a wide participant base.
So I think it's situation dependent. I think there are certain studies where it's not appropriate to open them up at places where they may not have an expertise in what the study drug is. I think there are a lot of instances where it's totally appropriate to do some of the treatments elsewhere, and you don't have to be coming back to the hospital, right? So, FDA approved immune checkpoint inhibitors, those are being used like holy water everywhere. And so people have a very good experience and good knowledge base for those medications and how to identify adverse effects early and how to treat them. I think that is totally fine and totally appropriate. I do think there are some other things, some sort of odder, less commonly, used novel therapeutic approaches, right? So I think that, CAR T cells, for instance, probably not the best idea to be doing that somewhere where they haven't done it before. That's a bias that I have. But I think more often than not, you can be on a clinical trial and not have to live across the street from the hospital where the site is directed.
That's great.
Or arrange to come to Swedish for a period of time. You come, you participate in the trial, you get the care that you need for 5 days, you go home for a month, you come back for evaluation. I think that all clinical trials that are done nationally often have to recruit from a fairly large web. And that's one of the things that actually, I think, brings people into an institution, is that you have clinical trials. And I think it's very important to be not just providing a standard of care, but a standard of care plus for those individuals who either have failed standard of care or are eligible for trials where standard of care can be augmented. So I think that that's something that's really a national thing, and we're fortunate enough to really be able to add that here as well. Sam, I was going to jump back into the lung cancer screening realm just for a minute, if that's okay, and talk a little bit about that.
Yeah, let's do it for a minute, and then we want to move into a couple of questions that we've had come in through the chat before we run out of time today.
Yeah, so so lung cancer screening is specifically for individuals who are at risk for lung cancer. And let me talk a little bit about lung cancer and use that word. It's a word that's used generically because cancer and the lung doesn't necessarily mean that it's lung cancer. So unfortunately, other diseases can metastasize to the lung. People can have colon cancer that can go to the lung. People can have other types of cancer that can go to the lung. who perhaps would benefit from surgical intervention, right? So it doesn't necessarily mean that these individuals don't benefit. But we need to be clear that when we're talking about lung cancer, we're talking about the origin cells, the cells that went awry are cells that originated in the lung, not cells that originated somewhere else and migrated to the lung. That's called metastatic disease of any variety, when either the lung cancer leaves the lung or another cancer comes to the lung. Does it cause symptoms? Well, it can. It depends on what's involved. The meat of the lung, where the gas exchange occurs, has no symptoms. But when it starts to encroach on an airway or the wall of the lung that has pain receptors, people will have symptoms similar to an advanced cancer. But oftentimes, people who have an already identified cancer will be under surveillance. So you may have a colon cancer, you're under surveillance so that hopefully you can identify if that's changing, or a breast cancer, you're under surveillance to see if that changes somewhere else. But it's important to distinguish that the lung, yes, is the origin in lung cancer, but the lung can be the destination in a metastatic cancer. And so when Adam's talking about his research trials and things like this, we're mostly talking about things that originate in the lung. And at the current time, when we're talking about managing lung cancers and lung cancer screening, we're talking about a focused high-risk population. It is true that a number of cancers that are being identified are in never smokers. They're being identified in younger individuals. They used to be thought that many of these cancers were first identified in Asian women, but we know that now these never smoking cancers can fall into a much broader array of people. Unfortunately, at this time, there is no real screening for individuals that don't meet the high risk category. And there's actually a pretty good reason for that. The problem is when you take anything away from the individual and you put it in the population and you say, we're now going to expose this technology, this CT scan, to 30 million people who may be at risk, or 70 million people who may want to have a lung screen. The problem is you're going to find things. Now, I'm not sure if many people remember, but a long time ago, and I'm old enough to remember, you used to be able to go to the mall and get a life scan, a CT scan of the body that was thought to be sort of a health screen and pick up things. The problem is that they pick up things, that's for sure. But the problem is now you need to do something with those things. And if you take an individual who's high risk, 55 to 77, who's an active smoker, who or quit within the last 15 years and has more than a 30-pack year history of smoking, the person that qualifies for lung cancer screening, an enormous percentage of them are going to have an abnormality. In this study of 25,000 people who got CT scan, an enormous number of people on their CT scan had an abnormality. Less than 3% of them had a cancer. So you're talking about, even in the highest risk individuals, findings that we have to figure out what to do with. And we have to make sure that when we're doing screening, we don't do harms. We don't do excessive biopsies. We don't cause financial harms, emotional harms, physical harms. We need to make sure. But what this means is that this first pass at lung cancer screening is very 30,000 foot, age, smoking history. What we have to get better at is what Adam's talking about in terms of research is, okay, but who's the individual at risk? Can we develop biomarkers that we can do that are a blood test that look for it? And this is where lung cancer screening is moving. We're not there yet, but this is where it has to move. We now identify that lung cancer screening works, but it doesn't work for everybody because we identify lots of things. And therefore, we need to continue to move and push the envelope and figure out how to move from this sort of broad brushstroke, age, gender, anatomy sort of thing to something else. And so that's kind of where things are going with lung cancer screening, but we're not there yet. But it's fascinating to think that in my career, the U.S. Preventive Services Task Force, the one that recommends screening for everything in the country, used to not recommend screening for lung at all.
Wow.
And it's only been within the last about 8 years that it's now a recommendation. It's a huge advancement.
Wow. We've only got about 5 minutes left here, so I want to make sure that we get to some of these Q&As that we've received in the chat. I got a question a couple days ago that I want to make sure that I bring up. It's jumping right off of this screening conversation that we're having right now. He wants to say that he recognizes that in his own life, he's seen many, many people who develop lung cancer who've never smoked, and that their general practitioner was not looking out for lung cancer in them because they were non-smokers. What's happening right now to get those primary care providers better at recognizing someone who may be evincing signs, symptoms, that sort of thing?
I think education is really the key. Remembering that people who are never smokers don't fall into the high risk category, but people who do fall into the high risk category, the issue is education, and I think also offloading. We tend to point to the primary care doctor because they're the first point of contact.
Mm-hmm.
But we have to remember that our primary care system in this country is overburdened. These are people that are dealing with diabetics, they're dealing with emphysema, they're dealing with emotional problems, they're dealing with potential lung cancer, they're dealing with breast cancer. They are seeing multiple people in a day. So one of the things that I talked about through our research is how can we offload these primary care docs? And one of the ways that we're looking to do that at Swedish and working towards doing is creating these air traffic controllers that can sit here at Swedish, but work for the larger community. And again, pull in people who are at risk using our electronic medical record, identifying them, and then getting them screened and then tracking them and making sure that they go through the process. So I think that we can help offload them. We can provide education to our primary care docs, but we need to recognize how hard our primary care docs are working and figure out ways that we can support them, not sort of point out deficiencies. And so one of the ways that we're doing it here is working to create this system of air traffic controllers to help with lung cancer screening in that broader area.
Great, thank you. I've got an anonymous question that I want to make sure that we answer because it'll be hard to follow up because he's anonymous. As a 65-year-old male, never smoked, whose father died of lung cancer, chain smoker for 65 years, would I be eligible for screening based on possible genetic predisposition? How often should an acceptable candidate be screened?
Yeah, so unfortunately, again, if you don't meet the current criteria, meaning 55 to 77, active smoker equivalent within the last 15 years, and have a 30-pack year history of smoking, there's no recommendation for screening. And in fact, we can't even get those scans covered. Genetic risk is something that is unique to individuals. And I do think that there is value in individuals who identify as a specific risk to work with their primary care doc to potentially look at genetic counseling and potentially figure out if there are unique ways for them to get screened for cancer. The problem is that the way screening works for the at-risk population is you get an annual screen. The study was 3 years. If you have an abnormality, you get shorter intervals. If someone is, say, younger and they have a risk that is, say, a family member, we don't know when that risk is going to kick in. So let's say an individual has a first-degree relative who has a lung cancer. They're 20 years old. Are we going to screen them with CTs for the next 40 years until they're in their 60s, when the potential for CT scans can cause some problems? So the duration for the active person is typically within that range, 55 to 77. For the person who doesn't fall into that high risk, I really recommend sort of individualizing it, working with a primary care doc, and potentially going to genetic counseling to try to see if there's a more elevated risk that we could screen in a sort of more outside the box way.
Gotcha. Thank you. That's definitely helpful. And so we're out of time for today. So I just want to really quickly wrap up by saying thank you so much for participating with us today, both people on the call and our physicians who have been chatting with us for the last hour. If you are interested in learning more about what our physicians do here at Swedish Thoracic, you can check out our website. There's swedishfoundation.org/thoracic. You can find out how to support the great research that these guys are doing here, or you can just find out more about their programs. You can also just shoot me an email, give me a ring. If talking is easier for you, I'd be happy to talk. And yeah, that'll do it for us today. There are a couple of people whose questions we didn't get to, and I apologize. I'll make sure that we follow up via email with you to get some answers for you. So. Thank you so much to our participants here today.
I want to take a second just to thank everybody who's listening and thank you for taking the time being interested in lung cancer. I think my closing word is going to be that in my career, lung cancer has gone from a disease that we were very nihilistic about. We had nothing that we could really offer to help these people besides conventional chemotherapy or surgery, cold steel. We now have a wide array of treatments. It is approaching what we can do for our breast cancer population. We could have early detection. We have treatments. We have emerging treatments. It is not your grandfather's Oldsmobile. Lung cancer now is a dynamic field with lots of options, and we need to think about it that way and preach that way so that people don't take a nihilistic view. We have something to offer for lung cancer, for sure.
That's wonderful.
I agree with that.
Hear that.
Masks and stay safe, everybody.
That's a perfect note to end it on. Wear masks, stay safe, and there is hope out there for many, many more patients than there once was. And that's thanks so much to research and to you guys. So we appreciate it.
Bye, guys. Thank you.
Thank you very much.